Welcome back to part 2. So, how do we begin? Patients are positioned on the right lateral recumbency. Why? If you remember in our first lecture video, this chapter, the cervical esophagus is found on which side of the midline, left or right? Any guess? It is found left of the midline. The surgical approach would be the left lateral cervical area, so this area must be clipped and prepped aseptically. Now, why the need for general anesthesia? The procedure does not take longer than 30 minutes, so why not just, do it with mild sedation? The procedure may not take long, but you need to minimize the risk of the activation of the gag reflex when the tube or the instruments pass through the pharynx. Pharyngeal stimulation causes patients to vomit, awake, or bite reflexively. To ensure efficient flow of food through the esophagostomy tube, lateral holes on the distal end may be enlarged to prevent clogging. If the tube is too long, the tip of the tube may be ultimately cut off. You also have to make sure that the tube is long enough so that the proximal end can be curved away from the patient's head. To facilitate this, we need to pre-measure the tube. Remember, esophagostomy tubes must only stay within the esophagus and never enter the stomach. As a rule, esophagostomy tubes, as seen in this image right here, that apparatus, they need to end at the level of or between the 7th or 8th intercostal spaces. So let's count. First rib, second, third, fourth, fifth, sixth, seventh. So in here, it could end within this intercostal space or even up to the level of the 8th rib. This ensures proper placement of the tube in the mid-esophageal to caudal esophageal region. If you push it too deep and too close to the lower esophageal sphincter, this will elicit vomiting. But how do we know when we are placing it? How do we know that we're already in deep? And how do we adjust? Basic. Count for the 7th and 8th ribs through palpation with your fingers. You can feel for your ribs. Count. Pre-measure the tube from the planned incision site on the lateral neck, right here, to the level of the 7th or 8th intercostal space as you palpate it. Mark the tube with a permanent marker. Alternatively, prepare the tube of the same size and length of what you are going to use and make this as a guide for when you are placing the tube. Again, this ensures that the distal tip of the tube will end mid-esophagus or in the caudal esophagus. Important note during pre-measuring, you are already sterile and gloved. Your tube is also sterile because you are going to put it inside the patient's body. So if this is the tube that you will be using right here, you cannot use that anymore because it has touched the body of the animal, which was not aseptically prepped. Again, do not forget your surgical asepsis techniques. So what can you do? You can have 2 pieces of these tubes. Mark 1, okay? You can mark 1 right here. Put that aside, put it on top of the patient right here. Then get your sterile tube and you will use these 2 as a guide to make sure that you have placed the tube in the right position. In this picture, you see that the incision was already made on the lateral neck area. The tips of the forceps are already protruding out, and it is ready to grasp the tube. But let's slow down and find out the step-by-step procedure for esophagostomy tube placement in the next lecture video.